Okay, good afternoon. Welcome back. So today I'm going to talk about a very specific problem in febrile neutropenia, and that is the problem of the prolonged and persistent fever. So from very long ago, the guidelines have always suggested that one of the options available to us when faced with a patient whose fever persists beyond 3 to 5 days in the setting of neutropenia after chemotherapy, one of the options is to start an antifungal agent, right? So why do we want to do this? Because from very early on, people realized that fungal infections were one of the most important causes of mortality in patients who were receiving chemotherapy for leukemia. And yet there was no early good diagnostic tool. And as pointed out by Dr. Miti, you may want to do a biopsy, but frequently you can't because of thrombocytopenia. So there actually are two very important studies from many decades ago which support this therapy, this approach. So this is the EOR-TC study where people who remain febrile, despite being on broad-spectrum antibiotics for the past 96 hours, were randomized into either conventional amphotericin or nothing. And basically, what they found was that in terms of response, meaning in terms of the decline in temperature, it was far better slightly better in the amphotericin group without any change, whilst both groups persisted in being neutropenic. Unfortunately, there was no survival benefit, but they were able to show fewer documented fungal infections in the amphotericin group. This is the American version of the same study, where everyone, when neutropenic, was put on cefalexin, gentamicin, and carbamazepine. And then if the fever persisted beyond day 4, and if they still remain neutropenic, they were then randomized to 3 arms. Stop everything and watch, maybe it was a drug fever. Continue the same and watch, or continue the same combination and also add amphotericin. And as you will see, the numbers in each arm were actually very small, less than 20. So in the group that stopped everything, high rate of infections, all were bacterial infections, and many of them became very ill with hypotension and bacteremia. And that's the reason why, the hematologists and many of us will not go about stopping antibiotics in such patients if they remain febrile. What if you just continued and then there were quite a few infections and most of them were fungal infections? And finally, if you continued the broad spectrum antibacterial cover but added amphotericin, then you had these infections which actually are very, very hard to find and treat anyway, to prevent, like CMV and P. boydii, which is Scedosporium. So I think from here, you find that the data look convincing enough for people to support what is called an empirical approach to antifungal therapy in the persistently febrile neutropenic. But in the past decade or so, there has been a re-evaluation of these studies, which for a long time formed the basis of our practice, right? So people who re-looked at the data felt that they were underpowered. They did not use antifungal prophylaxis, or if they did, the antifungal prophylaxis was of dubious value. And statistically speaking, they did not prove the primary hypothesis. So all this re-evaluation has occurred because we live in changing times. And the major change, of course, has been the introduction of very successful, very efficacious prophylactic agents in the setting of febrile neutropenia, in the setting of neutropenia. So this is a very well published, very well quoted study by Oliver Corneli, All these patients were AML or MDS on a remission-inducing chemotherapy, and they were randomized either to POSA or to fluke or ITRA. So the control arm could have either fluconazole or ITRA. And as you know, posaconazole won hands down the rate of proven fungal infections, whichever way you looked at it, the probability of death, the rate of probable fungal infection, all these were much lower in the posaconazole arm. Voriconazole, voriconazole positioned itself as a competitor to posaconazole in the prophylaxis market, and they also ran a study against itraconazole, and as you can see, it looks as if the likelihood of survival is somewhat better in the voriconazole arm. So, in addition to the introduction of very good prophylactic agents, we also have good diagnostic tools. I'm going to talk a lot more about galactomannan, so I'll skip this slide now. But basically, we finally had a diagnostic tool that we still have that permits early detection of invasive aspergillosis. So in other words, we now have effective prophylaxis, and we have a fairly good diagnostic tool, fairly good only, not really the best. So is empirical therapy still appropriate? And that's the question that I will attempt to answer today. But before we get there, let's say we prefer an empirical approach. We at the AFWG did a laboratory-based study, and we found that only 23% of labs that we surveyed actually offered galactomannan test. So maybe it is not easily available. And as a result, in another survey, we found that many physicians in Asia would prefer or would adopt an empirical approach to antifungals in the setting of persistent febrile neutropenia. So in that case, which antifungal would you use? So lots of data, but I shall just refer you to this network meta-analysis. So in a network meta-analysis, you can compare antifungals that were not directly compared head-to-head, And basically, these are all the major studies, and as you can see, all of them did fairly well. ITRA did as well as amphotericin. The ambisome versus Caspo studies, again, not much difference, although many of us are aware that the safety analysis, I think the Caspo arm did better. And then you have a whole lot. Mica versus Vori versus liposomal, and so on and so forth. Lots of antifungal agents have all been studied, and they're all okay. But if you choose treatment response as the endpoint, then itraconazole looks better than amphotericin. But this is a network meta-analysis. And if you look at the number of times that a particular drug emerges on top, then micafungin looks the best. So micafungin has the highest rate of treatment response. So basically, all these drugs are available. Your hospital formulary can choose one or more of them. You probably would need more than one because there are other reasons to use one or the other. Okay, so now we move to the alternative. What if we don't want to adopt an empirical approach to persistent febrile neutropenia? So this is where we introduce the term, the preemptive approach to the prescription of antimicrobials. And this is actually, this was introduced in the field of solid organ transplantation, and particularly for CMV prevention. So the definition here is that this is a situation where the antimicrobial agents are administered before clinical infection occurs to a subgroup of persons shown to be at high risk of that infection on the basis of some marker, usually a laboratory marker. Right? And in preemptive therapy, the important concepts would be that there's no prophylaxis. You monitor a sensitive marker And in the setting of CMV, you'd be looking for the PCR or an antigen. And then you introduce the antimicrobial or the agent against that organism when that marker is positive. And when you want to conduct a study, the endpoint, of course, would be the number or the rate of cases of proven CMV, or in this setting, a proven fungal infection, right? And so people have looked at this in the setting of febrile neutropenia. And these authors, Bob Rubin, who has now passed on, but is recognized as the father of transplant ID, and Ben DePaul, who is now retired, concluded that they hope that in time to come, there will be less by way of empiricism in the management of febrile neutropenia. So what have people done? A variety of studies have been done. So there's something people, not everybody uses the term preemptive therapy. These are the Spanish, and they have used this term, a tailored approach. And these are the Italians, and they have talked about a diagnostic-driven approach, right? So let's look at the data. So basically, it is thought that when you have a diagnosis-driven or preemptive approach, you would save a proportion of patients from unnecessary antifungals, and you also save them from things like cost and side effects. So I think a seminal study which effectively supported preemptive or diagnosis-driven approach was actually this study. It's not a randomized study. In Leuven, Johann Martens and his colleagues decided that they would stop being empirical, and they would subject their patients to all these things. So they introduced regular galactomannan screening in their patients, and then if even one test was positive, they would proceed to a thoracic scan, a CT scan of the chest, and that was positive, they would do a BAL and again look for galactomannan and fungi and everything else. And basically, this is what they did. It's a very complex slide, but basically there was much less use of antifungals in comparison with a historical cohort. What did they miss? Only 2 cases of Candida glabrata fungemia, but this was easily picked up by blood cultures, and 1 case of cerebral mucormycosis, which would have been very difficult to pick up anyway. But were there problems? Yeah, I suppose there's a problem of false positive galactomannans, which I will go into in my next talk. So the mortality was 18%. 7 of these deaths occurred in patients with a positive GM. And although they were able to demonstrate evidence of disease on autopsy, invasive aspergillosis was actually not a primary cause of death in most of the 7. There were other things that caused death, such as CMV and toxoplasmosis. But remember that it may not be easy to replicate what they did, because they are very high-end, well-funded European unit. So every neutropenic patient was housed in a HEPA-filtered room, and they gave fluconazole prophylaxis, and they were able to do galactomannans daily. Okay, now is there a real RFCT or head-to-head comparison? So this is the Australian study where people were randomized into 2 arms. So in the standard arm, if there was persistent fever in spite of 3 to 5 days of broad-spectrum antibiotics, then you do all these cultures, and then you start empirical antifungals. In the other arm, this is the biomarker arm. I've blown it up here. Then you would keep doing galactomannans and PCR. And if the galactomannans and PCRs were all negative and the patient was afebrile, then nothing doing, right? Just sit tight. But if the patient was persistently febrile and neutropenic, go on to a CT scan of the chest, and then if there are abnormalities present, treat as for invasive fungal infection. If you have a positive PCR or galactomannan, then go straight to the CT and then treat accordingly. So basically what they found was that the biomarker arm had much less, almost half antifungal use, but there was a little bit more by way of probable invasive aspergillosis. But here, no difference in mortality, and some of the other markers were also not different. So basically, about half the patients who receive a diagnosis of probable or possible invasive aspergillosis were diagnosed in the absence of persistent fever. So meaning that they probably caught the infection very early. And if you look at it the other way, had they applied the biomarker strategy to the standard diagnosis group, then about a quarter of the patients who received empirical antifungal therapy would have been diagnosed with probable or possible IA several days earlier, right? Okay, so this is the tailored approach that I was talking about. This group did not give prophylaxis at all. They also did not give empirical antifungals, but they recommended, that you would do certain things, right? So this is what they did. So it depended on how ill the patient was. If the patient was very ill, with severe sepsis or septic shock, then just go ahead, give caspofungin or liposomal amphotericin. But if there was a suggestion that there would be a pulmonary focus, maybe pleuritic chest pain, then they can give voriconazole. Whereas if it was an abdominal focus, then give caspofungin. So abdominal focus might be hepatosplenic candidiasis, right? Many of those patients would have right hypochondrial pain. But if the patients remain quite well, no shock, no severity, just do blood cultures, do the galactomannan twice a week, do a CT thorax, do a CT abdomen, and investigate as dictated by the patient's symptoms and signs. And this is what they suggested. So it's a rather complex chart. So if you find, for example, so what basically is that you should evaluate to look for the focus of the fever. So what is the problem? And if there was a pneumonia or something wrong in the chest, go ahead to do thoracic scan, a BAL, check for galactomannan, maybe give voriconazole. If the issue is rhinosinusitis, you can do either vori or liposomal amphotericin, depending on whether mucosinusitis is a bit more common in your center, and so on and so forth. Then abdominal focus, well, this may be enteritis, and an antifungal. Treating S for disseminated candidiasis would be appropriate. So this is what they did. So basically, this is what happened. And there were only 12 proven or probable IFIs. And in its ability to select patients who did not require an antifungal, the tailored approach had a sensitivity of 100% and a negative predictive value of 100%. That means if the patient really was negative for GM, negative by way of CT thorax, negative for sinus symptoms, negative for brain symptoms, there was no possibility of him having an IFI. So how did the results of this Spanish study compare with this famous New England study, right? Caspo versus liposomal. And this study had a success criteria for success. So if you apply these criteria to the Aguilar-Guisado study, then you find that the tailored approach had a success that was much higher than that of empirical antifungals, more than double, 76%. Whereas the caspofungin arm had a success rate of about a third, liposomal amphotericin arm also 1/3. Right, so these are the mortality data. It's very hard because you would have to compare with other patients, right? Now, this is one about posaconazole prophylaxis, about what you do in the setting of posaconazole prophylaxis. This is an Italian Italian study. So in the Spanish study, they all did not have antifungal prophylaxis. But here, they all had posaconazole prophylaxis. Now, this is an observational study. So Livia Pagano collects data from all these Italian centers, and they just give him the data. So he divided them into whether they receive empirical, preemptive, or targeted therapy. So targeted therapy means you must prove a diagnosis before you start antifungals, right? So these are the results. So under the empirical arm, these are the numbers you get. This is the preemptive arm and this is the targeted arm. So proven infections, you find there are only 2 out of 102 in the empirical arm. 0 in the preemptive arm and 2 in the targeted arm. Mortality about the same in both empirical and preemptive arms, but very high, of course, in the preemptive arm, in the targeted arm, right? This is another study. This is from London, where instead of using galactomannan, they use a CT as a trigger for caspofungin in a bunch of allogeneic stem cell patients. And basically, they said that about half, 54%, would have received antifungals had the traditional approach been used. But with a revised strategy, only 17% received caspofungin. And yet, interestingly, no IFI was diagnosed in the first 100 days in people with a negative CT. Right? So, but most of the guidelines do not recommend that you use scans alone because for this reason, CT does not distinguish between fungal infection and other etiologies. CT cannot tell you which fungus, and it's best to combine with some sort of microbiological test, culture or non-culture based. Okay, this is another trial. This is by the French. This is empirical versus preemptive, almost the same design as the Australians, except that the trigger in this study consisted of many different things, including septic shock, skin lesions, periorbital inflammation, and of course a positive galactomannan, but also things like periorbital inflammation and septic shock. So you'll find that in this study, the preemptive arm did not do as well, right? But this study has been criticized in many ways. Of course, the preemptive arm had more fungal infections, 8% compared to 2.7%, right? But if you go back to the original definition of the preemptive mode of prescribing antimicrobials, then I think in some of those patients, the investigators must have waited too late, right? Because you must do it before clinical infection occurs. So in other words, it's best to do it the moment galactomannan, or if you use beta-D-glucan or PCR, if one of these things become positive, rather than wait till there is some clinical symptom like a skin lesion, right? Or periorbital inflammation, right? So this is targeted therapy, not diagnosis driven. So you will see that in general, there's you do get more IFIs diagnosed, right? So why is that the case? So someone has tried to explain it. Empirical therapy is given to patients with only fever, right? And as you know, fever means many things. Today, with much better diagnostics, we know that some of these people have Clostridium difficile. For example, in this day and age where we have a lot of CP-CRE, we also have that CP-CRE bacteremia. So sometimes you can get a more resistant bacteria. Whereas preemptive therapy is given to patients with a little bit more than just fever, right? And that more usually takes the form of a galactomannan or a PCR or something on the CT scan. And therefore, it is not surprising that IFI is less common in the empirical arm since no one knows what these fevers are. Whereas preemptive therapy, you are actually engage in a process of looking for a fungal infection, right? You're testing for galactomannan, you're doing a CT scan, and you would find it. That's what these investigators are saying. So this is a more recent meta-analysis. So in truth, despite what people have found, if you look at all the studies, including some of the smaller studies that I did not go through, some of the less famous studies, you find that all in all, in terms of a summary statistic, there actually is no difference in terms of death between the two types of approaches. And if you look at these IFI associated mortality, there's no, you actually don't have that either. So you can look at various outcomes. Overall mortality also less. Sorry, what was the first slide then? Antifungal use is definitely less. Sorry. IFI associated mortality, no difference, and overall mortality, no difference, right? So if you prefer to look at numbers, then these are the numbers. It's a very good meta-analysis. They use two different statistical methods to look at the risk of different outcomes in the two arms. So in real life, it's not so easy. Most of these studies have dealt only with patients with AML and MDS on remission induction therapy, and some studies have included allo-HSCT patients. But we haven't had the chance to talk about patients with ALL, for example. And nowadays, patients are living longer and longer. Multiple myeloma can be treated with tandem autologous transplants followed by allo. And then if they still relapse or if the M-band doesn't come down, there's so many other things that you could try. Daratumumab, etc. Ibrutinib was mentioned by Dr. Chakrabarti as a risk factor. Should you be prophylaxing such patients? All these studies actually have not been done. And what should the approach be if mole-active therapy prophylaxis is not used in such situations? So my summary would be that if you adopted a biomarker-based approach or a preemptive approach or a diagnosis-driven approach, there actually is meta-analysis data to show that it's not worse than the empirical approach as opposed to the two sentinel studies published in the 1980s. It will save a proportion of patients from unnecessary antifungals, but it makes good bedside medicine more crucial than ever, right? You mustn't miss that rash. You mustn't miss the cheek pain, which may be the first sign of sinusitis. You mustn't miss that pleurisy, which is the first sign of invasive aspergillosis. But you also need a good support system, right? You need to be able to get a CT on the same day, on the same afternoon. You need a very responsive bronchoscopy service. You need, of course, galactomannans to be done several times a week, and perhaps even therapeutic drug monitoring. So thank you very much.